So let's open it up to the roundtable and to the audience at the same time. There's no reason to distinguish one from the other. We'll take everybody's comments related to what we heard from the panel and anything else perhaps that you'd like to bring to fore. Let me just ask a question while we have everybody rush to the microphones at 4 o'clock in the afternoon. Let me ask you a question. I sit on the board of a hospital, a large community hospital within a large integrated delivery system. And this issue of community resources and how to involve the community comes up all the time. And not only that, we have maybe 5 zip codes within that community. It's the market of that particular hospital. So how do you assess with, in specific communities, their resources? How do you identify trusted partners that really want to improve community health or really want to be involved in the community? How do you identify, because the social determinants of health in all those zip codes are different. Not a question that there are more food deserts in one, there are more concerns about other issues, education, housing, et cetera, in another. How do you identify? I'm not going to ask about what the metrics of success are, but how do you identify that? How does the chairman of the board answer that question when it comes up every 3 months?
I think it's already been said today, and that is that what is the level of passion of the interest in that community? So, if the healthcare organization is truly wanting to engage in the community and identify that, whether that's a good fit, I would look for champions that are already integrated into the community. They're already a part of the community, and this is, it's a good fit if you can already tell their level of investment. And I think a lot of times in those initial conversations about engaging with partners, you get a sense right off the get-go whether or not this is something that is coming from a place of, deep concern and commitment and passion, or if it's coming from, we need to check this box. And if it's we need to check this box, then I don't think they're your partner. I don't think that's the direction you need to go.
I also believe, we have a community advisory committee, of course, at the hospital that reviews all of our community outreach programming, that is made up of stakeholders from a variety of different community venues. And we have a pretty interesting county as well. We also fall back on some of the county health rankings and look at those so that we can help steer the conversation of what we really need to be working on and change. And I think knowledge is important when you're really looking at a partnership. Is the knowledge there to work together?
I think also, Bernie, to answer your question about where are the resources within the community, one of the things, the obvious ones is to look for who has the responsibility for disseminating that currently. So, for instance, in North Orange County, which is a medically underserved area where our offices are, we run and administer a family resource center, which is a social services agency, and the marching orders for that family resource center are to do intake on individuals who are looking for help and provide them access to resources within the community. And so all of those resources are all groups that are either, partners, funded partners, unfunded partners, groups to whom people can be referred for whatever services that they need. And so that's always a good starting point. I think, also in La Habra, where we're located, we've actually really mobilized the community quite a bit. We have people from the city, the Chamber of Commerce, the faith-based community, nonprofit organizations who sit together and come together in a regular bi-monthly meeting and talk about programs and services, how can we help one another, and have a little profile each time on one of those particular groups who provide services within the community. So to the extent that your community is already engaged, you may have some of those other ancillary ones, but at a minimum, you're going to have one of these social services agencies like a family resource center. That's always going to be a good place to start.
So just let me tell you what we did, since I'll give you the answer to what we did after going through this for a number of years. We went to our family health center, which is not quite an FQHC, but similar without the FQHC designation. And we actually posted on the walls we went right to the community that probably needed it the most, and posted on various walls and had the entry nurses and whoever else was at the desk ask the question, would you like to be on a community advisory board to help us do the following? And I must say, that was really very successful. We found individuals who probably never would have before involved themselves, but here they were as a patient or a visitor or a family member of somebody who was at the family health center, recognizing the need, and really came forth. It was a very good effort, and we had very good results, just to give you that additional background. Okay, Cynthia.
Well, I think Jennifer was first.
Jennifer, then Cynthia.
Okay. Jennifer Dillahay, Roundtable member in Arkansas Department of Health. I'm struck with some of the references that you made, that panel members have made, with regard to some of our policymakers and the future and the need for policy, even though there wasn't a lot in the literature for this review. And this notion of community being constituents of policymakers, and how might we bring that together? It seems to me that some of the champions you've mentioned are the policymakers, and they can relate to health literacy, because I think there's probably not a person alive who hasn't dealt with a health literacy issue. So for the future of communities and health literacy, how do we leverage that so that they can serve as constituents of some of the policymakers and give input? So the policymakers may not be part of their community, but the community are their constituents. Does that make sense?
I think I follow you. So a pillar of our work is around advocacy and policy, and we look at that in two ways. We've got working groups around three initial focus areas of tobacco, infant mortality, and hypertension. And we have invited policymakers, Metro Council, to actually those at a state level to be in those working groups. And some of them have come and interacted. And then secondly, we do support, or we have supported legislation related to those three areas as a collective with other partners. Okay. I'm not sure if that gets what you're mean, but.
I think another one, Jennifer, is this, it's a theme that's been stated quite often today, and it's this notion of relationship building. And so when we talk about collaborators, I think we need to make sure that our legislators are part of the ones that we consider as well. And I've had some very good and some absolutely horrid interactions with legislators, depending upon how well the agendas match up or don't match up. Most of the time, if it's a community-based intervention that's a health-based one, you're probably going to find a pretty a willing ear. In the health insurance literacy area, and I'm sure Katina can speak to this one too. Depending upon where you're at politically, you may or may not be in support of efforts to educate people about health insurance, how to use it, and rolling out any of those particular initiatives. But I think it's that notion of identifying as broad a spectrum of people within the community who have a representation or a stake in that community as possible. And sometimes when you get a legislator, it's the same thing. Don't come to them at the last minute saying, oh, by the way, we did this whole thing and there's a policy piece, and so here, this is for you. If you build that relationship and say, look, we're in the community, we're working, here's some of the things we're doing, just want to keep you posted, and the fourth or fifth time, oh, by the way, here's a policy opportunity, then, that might be a little more, they may be a little more likely to work with you on that.
Cynthia?
Okay. So I have Cynthia Bauer from the Horowitz Center for Health Literacy at UMD. So I have sort of two comments, questions. returning to some of the themes that we tried to raise in the paper. So the first theme and question has to do with the scale of the problem that we're dealing with, the problem being limited health literacy. And as one of the people who put forward and has promulgated the 9 out of 10 statistic coming out of the NAL data, I'm a little worried that we've become a little numb to what that means, right? 90% of our society is a lot, right? We all repeat that 9 out of 10, but 90% at the end of the day is a lot. And the reason I'm really reflecting on this now as a part of our discussion is while we were wrapping up the paper, there was a media story talking about the state education plans that states are all having to submit to the U.S. Department of Education under the new federal education law, so the law that replaced No Child Left Behind. And the part of the discussion in the article was talking about the way some states were presenting their improvement plans. So they were focusing on one state that said they were going to increase by 2/3 the number of students that were going to be at XYZ level. And some of the critique of that was even after, I think, like a 6 or 8 year investment, they were still going to have about half of their kids below proficiency, right? That's after like many, many years of investment, they were still going to have half of their kids below proficiency. I mean, that's shocking, right? After that many years of investment. So, and we heard Ariella say today, after the number of years that they've been at it, they've reached 140,000 families out of 1 million, right? 140,000 families out of 1 million. So I want to put forward this issue and potentially as a question is, what are we gonna, as a community going to do about scale, right? We've really got to grapple with scale, and we saw that in the review that we did. The sample sizes are small. It's great, you know, that we heard all of this practical advice about dealing with communities. That's really important. But I think we've got to kind of grapple with the scale of the problem here. So that's kind of comment question number one. What are your thoughts about scale? And the second one has to do with, again, sort of the practical advice about working with communities, which is very valuable, and sort of maybe setting that up a little bit as different from the science. And what I mean by that is there's a little bit of an undercurrent, I think, of what I've heard today, that science is for us, right? Science being for the researchers. But science isn't just for us. I mean, science is actually of value to the communities that we work with, right? So I think one of the ways that we leave communities with something more than what they started with is to help them grapple with science as a way of knowing the world, right? Because that is what the scientific method is about. It's a way of knowing. It's not the only way of knowing. It is a way of knowing. And so I would like to kind of have your comments too about how do we, you know, continue to advance the science in light of everything that we heard today about this practical advice of working with communities. Because I feel like we want to kind of keep those two things connected, right? That you deal with the peculiarities, the particularities of your community, but at the same time with that scientific rigor that, you know, maybe isn't quite there in the field yet. So your thoughts about that. So those are kind of my two big themes and comments.
Don't leave the podium, Cynthia, because I'm going to ask you a question in a few minutes. Go for the panel.
So on the scale of the problem, one of my major concerns with the Life Enhancement Program was, gosh, only 20 people come through this 12-week program at a time. That's not a lot of people. And then when the research came back, the post-assessments came back of how many people did you share this with? And it was, I shared this with 10 to 15 to 20. I had one woman who had a radio show, and she said, well, I don't know, how many listeners do I have on my radio? Because I talk about it every morning. I share the information on the radio every morning. And there's, you know, there's always that story of the little boy on the beach with the starfish throwing one starfish back in at a time. And the man says, what are you doing? And he says, throwing the starfish back in. He says, well, the beach is covered with them. You're never going to save them all. He said, but I saved that one. And that's that's sort of, unfortunately can be really overwhelming thinking about, gosh, we have all these people. How do we get to them? So we get to them as we do. We've had spouses who didn't go through the program lose 40 pounds because the wife started cooking differently and she started walking without him, so he started walking with her. So the scalability is definitely an issue, and can be really overwhelming until you try to bring it down to who did I help today, right? We have a joke in our office of saving people one blood pressure at a time when we go out to do blood pressure clinics, because we do. I'm going to skip the advance the science question because that's beyond my brain. I apologize.
I was going to attempt the scalability one too. The other one is I have to think about that a little bit more. But, when I think about, it's not just, I think some of us tend to think of all the people out there that need to improve health literacy, but we're talking about the healthcare field too that needs to improve their health literacy. They're part of that 90%. And so I think about the accreditation certification initiative that is going on right now, and really applaud that, because thinking about public health, hospitals, healthcare accreditation, medical schools, embedding all the health literacy principles, education, and policies, having that be a part of all those systems, I think can do a great deal of good in terms of scalability, and so that it is embedded, if you will, into the DNA of everyone that is coming into the field or is currently in the field, which is harder to do. So I think when you have that side of the equation also addressing this, you can reach scalability pretty efficiently. I'm going to think about that science one a little bit more.
Why not? I disagree that, or start over, because I don't know if you posited that researchers think that science is just for them. I certainly didn't think that way. I didn't grow up in a family of scientists. I kind of grew up and found myself to be one. When you are teaching people about healthier eating or managing their blood pressure or their glucose levels or whatever it is that they have to monitor, or teaching parents how to care for their newborn with no issues, or child with certain issues, or parent who is in decline for one or multiple reasons, you are teaching science to all of those people. When librarians are teaching that teaspoon and tablespoon thing, they are teaching them numeracy. They may not realize that or perceive it as learning health science, but they are, Cynthia. They are. And we know that we know scientifically, and we know practically, that when you are learned in one particular area, if you learn about teaspoons and tablespoons, you can transfer that knowledge to caring for your parent. And when it comes to advancing the science, so we can disseminate evidence-based interventions on a large scale, I think we need science to uncover exactly how that process described in the definition, ongoing definition of health literacy, because I think we do not have a thorough understanding based on the literature you've covered and other literature I've read. I don't know if we have seen a lot of health literacy specific work on the cognitive and biological processes involved in the exposure to, perception of, and processing of health information to make healthcare decisions, because social environment, state of health, state of illness, state of stress, contextual environment of whatever setting in which that is all going on, all of that has an influence on what's going on in mind and body. And all of that has to be accounted for in health literate or health literate people. And understanding how that happens can help us reduce that 9 to 0, or somewhere darn close.
I'll just add, our experience with community academic partnerships has been a help in seeing the possibilities of advancing science and keeping the practicality of the community. But there are like real barriers to just like working with the RIB to publish your work in the community. That's a infrastructure challenge for community-based organizations often, and having the research community or the academic community involved in helping guide community programs into, so that you can publish, so that you can add to the field, I think is one particular solution and one way to go about that. But it really requires the two working together, because we don't have the capacity in our organization. Just having a person on staff to just work with our RIB approval is, there's a lot that goes into that. And we're really fortunate that, she had a medical degree, so that she had the capacity to do some of the things in a project that maybe just someone else we would have hired might not have.
Cynthia, I like the idea of creating a learning health system around the issue, because really that's what we're talking about. If we can formalize it as a learning health system, bringing down the time of discovery from 17 years to 7 months, using learning health system principles, it would seem to me that would help the science. So maybe that's a direction we could think about. But that was a very perceptive question that you asked about scale. So you've probably given it some thought. What are your thoughts? I don't mean to put you on the spot, but I do. What are your thoughts when it comes to scale?
I think we need to think bigger. And I, say that because I spent so many years of my life kind of thinking, I guess, at the national level about problems. And I think, research often proceeds, kind of in these small kind of incremental steps, right? Because we have to, do our pilot study. Maybe we have to do the pilot study again, or maybe with a different community. And, we sort of build this knowledge up over time. But, one of the things that, and the reason I kind of brought up the science is because it was very challenging for us to kind of say something comparatively about these different interventions, right? We came up with these categories, right, based on either setting or topic or whatever. But there are deeper things about the interventions themselves, like to what Bill was saying about how they actually work, what are they changing either about people or processes or communities. I mean, that's still, I think, the black box. Now, whether the researchers themselves know that information and it's just not in the papers for some of the reasons that were talked about earlier, like publication bias towards reporting certain things, I don't know about that. But I think we have to kind of think bigger. It's like, okay, so we've done several studies now working in this adult literacy health literacy partnership model, right? And I was very gratified to have most of those papers kind of reference the National Action Plan as being a catalyst for that. So that was really great. So now that we know that, right? Now that we know that there are curricula that work and that you can, get teachers on board, adult education teachers on board with this, and that students are interested. What do we do with that knowledge, right? So can we do it citywide, right? Rather than picking off one program at a time, can we start to think about a citywide intervention, right? Is that possible? What about a county-wide? I mean, we just weren't seeing things happening at that level. And so to me, that's where I'd like to kind of push people to start thinking about, is as you start thinking about these partners, let's go up a notch. Let's think about those partners working at that broader scale. And so, for example, there are plenty of associations within states that could take you even statewide, right? So let's start thinking, I think, at a little bit grander scale, and maybe that sort of gives a lot of the true community-based people, like the sweats, because you're thinking, hey, I'm already struggling to kind of fund what I'm doing at this very small level. But we're never going to get to that bigger level if we don't start asking for it. And so that's what I guess would sort of nudge people towards, is to say, let's start asking for something a little bigger and start applying the knowledge that we have and start seeing if we can roll this out at a bigger level and testing it out. And, you know, starting to get things that we can take to policymakers and say, we're not just picking off one school here, one school there. The third graders, right? It's great that it works with the third graders. Does it work with all primary school kids? Does it work with primary school kids and middle school kids? Does it work with primary school kids in rural and urban? I mean, there's so many different, you know, kind of mashups that we could come up with. I'm just saying, let's think a little bigger.
Thank you. Andrew.
Okay, changing gears. So breathe for a second. It's all good. Notice how many younger people are still here, by the way? Isn't that cool? You must be getting class credit. Anyway, almost by design, because maybe it was, this panel sort of shifts, right, from people, while you are working in community, you also, and Bill, I include you in the NIH in this, are building community as part of your core mission around the hospital in Berkshire County, around Wisconsin literacy in Wisconsin, across Nashville, and within the NIH, which is different than what we've been talking about all day. And Carolyn came up with a great example of an incentive that worked for the Chamber of Commerce to help build that community. So for all the people who would like to build a community that aren't in the room, but they're listening on the webinar, and those who are, tell me more of your incentives that work for different audiences to help build a community, please, across the panel.
Well, to actually build the community, or to, I mean, when we work in communities, we often think about incentives and what the community will bring to the table. That you know, like I'd mentioned before, capacity of the community to work on the intervention. So I'm not sure if I'm getting your question correct or not, but for the information that we learn from the communities we work with, we incentivize them to participate. So we have a patient education, or a patient advisory council right now on a medication label project we're working on, and the valuable information that we've learned from our patient advisory council has really informed this project to a great deal. And so for every time that Patient Advisory Council meets, they've come together from different backgrounds, different places in the state, different education levels, different socioeconomic status, but they've come together and they've formed this community around how do we change a patient medication label in Wisconsin to make it easier for everyone to read. And for their work and the knowledge that they've imparted on our program, they are incentivized every time they come, you know, they gather and meet. And yes, cash and food, and you know, but they've also, what's been interesting, and I was at the last meeting last week, is they talked about the community that they never thought would come to, you know, like we were talking around the table and they just said, this is really interesting because if it weren't for this project, I would never be engaging with, you know, all of you around this table. But because we're all interested in changing how the way medication labels look in Wisconsin, you know, you have now become, you know, a friend and colleague of mine, and they outside of program time or patient advisory council time, they have talked to each other and they've counseled each other on different life situations, which was really rewarding to hear them share about at last week at our last meeting.
I can speak for, in La Habra, where we're at in North Orange County, the collaborative that I referenced earlier, there's about 75 groups that are all different entities in there. And there's a way that these things sort of feed upon one another. The larger it gets, when people come in, the larger exposure they get for their particular mission. So if you know, one of our newer members is head and brain injured children group. And there's a handful of people who knew that they existed. We knew because we run a family resource center, and a few other folks knew, but when they joined, now all of a sudden, they had an opportunity to stand up in front of the rest of the community and say, hey, we're here, here's what we do, and if you have a need for these particular services. And so that's one way to help build that community, to your point. Another is the, you know, as these groups, you know, when we're participating in events, we try to think about what are the missions of each of these particular entities and say, let's set this up so that we can give you an opportunity to achieve your mission. So if your mission is to, you know, X within a community, we're doing that. And if you come join us and work with this collaborative, you'll have an opportunity to advance your mission. To your other point about incentives, we have community partners which include like an organic grocery store called Sprouts. I don't know how many people have those in their community, but as a member of this particular collaborative, they bring fresh produce to any community event. And so as people, you know, if it's a you know, back to school fair, a senior fair, a wellness fair, you know, any of these particular ones, they're always there. And people know, if I come to this particular fair, I'm going to get a bag full of fresh produce that I can take home. Oh, and by the way, I'm here, so let me take advantage of all of these other ones. So I think that's at least a couple of ways that we do that in La Habra.
I just want to follow up real quick. Just a quick on incentives is that it's been said, you know, we compensate our participants generously in terms of their time. But when I think about how we compensate our patient advisory council compared to how we compensate some of the researchers and people that are on our project advisory council, it's two different worlds. And I think that the amount of information we've learned from both of those audiences, each one is equally as valuable. So just a thought about incentivizing the community that you work with.
Ruth?
Caroline, Ruth Parker, I just wanted to ask you very specifically, I was thrilled in the last year to be in a committee meeting when I heard Senator Frist talk about health literacy. It just made my day. And I wanted to ask you very specifically from your lens of working with businesses and the business community, what language and what framing of health literacy you are seeing, even in your own initiative or beyond, and any thoughts you have about engaging specifically the economic drivers of what happens on the ground within a defined population, since you're a part of something that's done that. And I think you're right, you referenced it. I think having Senator Frist as the person behind this has been a huge boom for what's gone on, and it's wonderful to learn from that opportunity. So I wonder if you could speak specifically to speaking to economic drivers like businesses.
So thank you. So in Nashville, it's an interesting business community, and some of you may be aware of this. We are a headquartered town for healthcare companies, and those companies operate facilities across the nation. It's our number one economic driver, about $80 million a year, $80 billion a year in revenue, along with the largest employer in the community. And I referenced that group when I mentioned the cocktail conversation regarding payers and health plans. And so it's been really interesting trying to bridge this healthcare business world with the community healthcare business world. It was a gap I didn't realize existed, and didn't really realize how deep it was until I actually jumped to the other side. So I think, I don't know that we found any kind of magic solutions yet, except being very deliberate in our conversations and making sure that when we're talking about the social determinants of health, especially to that business community, they know exactly what I'm talking about. And reminding them with data. Did you know that we have a rate of infant mortality in our community that's on par with Libya and Russia, and how that impacts the future economic growth of our community?
Rob?
I think Michael was first.
No, you haven't had a chance today.
Okay. Rob Logan, National Library of Medicine. Scale. I don't think it's quite the problem that you think it is, okay? The reason for my confidence is my old friend, the late Everett Rogers, the father of diffusion of innovations. His name's come up. His name hasn't come up, but the concept of diffusion of innovation has come up quite a lot today. The concept of diffusion of innovations is no ideas, nothing new, other things diffuse through society, through everybody, and you have to accept that. But the argument is strategically to reach opinion leaders, not early adopters, not the people who come first, but the opinion leaders who have an influence on everyone else. If you do that, his argument is, scale it isn't naively become a non-issue, but it becomes far easier to think through, to strategically plan. And I think it makes it more possible to say we'll never reach 90% of the population, but if you follow Ebb's ideas, if you reach certain opinion leaders in certain kind of communities and have an organized way of doing that over time, you will reach a good percentage of the population. I remember a conversation I had with Ebb about scale once. We were standing in an area in Albuquerque. He was a professor at the University of New Mexico. And I was lamenting, how are we ever going to take an issue similar to health literacy, how are we ever going to reach people to do that and use mass communication to do it? And he looked at me and he said, Rob, he said, where are we standing? And we were in a very nice area in Albuquerque. He said, do you realize what this place was like 60 years ago? You realize all the change that's happened here and what a much better community this is? And if you want to talk about health, said, look at all the innovations and things that people here have accepted as a part of their way of life. He said, it's remarkable. He said, and that's in a half century. He said, you have to think differently about change. He said, he argued with me than the way most of us think.
Michael?
Michael Pasha-Orlo, long-time listener, first-time caller. Bernie, you said before something about learning systems, and the thing is that we're talking about communities now, and they don't have QI departments. And
Well, but you don't need a QI department to do a learning health system.
we'll talk about that later. I think that in the end, several of our comments have strayed a little bit back towards health system settings. And another thing that we maybe have done is, talk about 90% or 90 million or whatever. Those numbers also come from our old thinking about the individual level health literacy conversation. And really, I think coming back to skip ahead, to skip the decade that we spent talking about that, focusing on that, is to say, what are the attributes of a health literate, although I cringe with the phrasing, but the health literate, community-based organization. And so I can't say that. That's going to have to come from the organizations, and yet we could facilitate that conversation. And if we basically had a toolkit oriented towards the community-based organization, I'm a faith-based organization. I want to do my role, my part in the health literacy work. How do I do that? What are the attributes of my organization? And that would help skip, the 7 years or so that we were wandering around till we got to that idea. So actually, the authors of that are here, and just we need a new version. But we can't just create it, right? It has to come from with the partnerships, So anyway.
Steve?
Yeah, thanks. Steve Rush, United Health Group. And a couple things were just said that really brought some ideas to mind about scalability. And I'm not quite sure that there's a real big difference per se between rolling out health literacy within a community and rolling out health literacy within an organization. Certainly, organizations vary in size, and so do communities, and there's a level of diversity and equity in both. Carolyn talked about something that really struck my mind as I was thinking about how we rolled out health literacy within United Health Group. And that was when you talk with the Chamber of Commerce, you use Chamber of Commerce language. We've talked today about the concept of speaking to people where they are at the time that they are. I'm reminded of a time, I'm a psychologist, and I'm reminded of a time that I had a patient who was an astrophysicist, and boy, that person knew quite about numbers. But when it came to healthcare, not so much. And then I had a patient who was a physician and had a cardiovascular issue. Well, when he got out of the hospital, they said, "So doctor, what do you think about this?" With all the biochemical changes and everything that went on, well, here's this doctor, medical doctor, but he couldn't make that processing, low health literacy. So I think one of the things that came about for me was, what's the motivations of each of the people that I need to talk with? What's the lever? And in Hill Street Blues, the gang leader said, "Hey, Frankie, what's my sugar?" So what's the sugar? What can I tell you? And I think that realistically, it's what I learned about working with gangs. When you go in, if you use psychobabble, you're not going to be there. But if you could use the language of the community, if you could use the language of the people in the street, and then you develop your commonality, and then you lever up, and you get people talking the same language, that's the same kind of thing. Not only Everett Rogers, but Malcolm Gladwell, the tipping point. And I think based upon today's discussion, we're beginning to get to that tipping point. We've had mavens, we've had salespeople, some people are early adopters, but I think that we're moving ahead. Today's discussion really was very helpful. Thank you.
So we'll start in a moment. Thank you very much for those comments, and I think this has been a terrific panel. But I just want to end this by with the Don Berwick story, that specifically when we're talking about scalability and learning, and some of you maybe heard me use this Don Berwick story before. Don Berwick, most people know Don, was at the graduation of his daughter from Yale Medical School and was the keynote speaker. And when he got through talking about learning and the importance of being who they're going to be shortly as physicians and healers, etc., he said, one thing that would really be good to learn is take off your white coat and stand amongst your patients, your friends, your peers, and listen. Take off your white coat. And so when I think about that, I often think about trusted people and the importance of what we're trying to say, and that is stand amongst those who need you most and listen. And I think that's what Don was trying to say. In any event, thank you very much. This has been an exceptionally good panel, an exceptionally good day. I do want to also thank the staff for putting this together. I think they did a terrific job. The day would not have been as smooth without Melissa and Alexis and Lila. And so I want to thank you very much and appreciate it.